Hello, my name's Mark Williams. I'm one of the orthopedic registrars, and today I wanted to talk about supracondylar fractures. So, the objectives of this Pearls of Wisdom presentation was to talk about three things. Firstly, how to assess a person presenting with a supracondylar fracture, both the clinical findings and the radiographic. And then secondly, I wanted to talk about some of the management decisions. And lastly, just briefly touch on some of the controversies and my take on the fixation methods. And really, I aim just to give some sort of tips and tricks for more junior members of the team when assessing these injuries. So, supracondylar fractures typically present in the pediatric population that's around about 5 to 7 years old, although clearly it's not confined to this age range. And the typical history is a fall from a trampoline or monkey bars. And they present, as you'd expect, with pain and an unwillingness to move their elbow. And so really with this group, the first thing really will be obtaining a diagnosis, and so you'll be ordering them radiographs fairly early on. And so that leads me on to really assessing pediatric elbow radiographs. And a really high yield topic and mnemonic to remember is the mnemonic CRITOL or CRITO, which outlines the order in which the ossification centers appear on an elbow radiograph. So they appear in the order of capitellum, radial head, medial epicondyle, trochlea, olecranon, and lateral epicondyle at the rough ages of 1, 3, 5, 7, 9, 11. And this clearly is not an absolute in terms of the ages or an absolute in terms of the order, but it does allow you to know that when you're looking at a 5-year-old's x-ray, you can be expected to see the first of those three, so the capitellum, the radial head, and potentially the medial epicondyle. And for example, if you can't see a radial head ossification center, then you'd be concerned that there's either a fracture of it and it has been displaced and is hiding somewhere, or potentially the order of ossification centers is slightly different in this child. But more specific to supracondylar fractures, there's the order in which I look at the pediatric radiograph will first of all be to look for what's known as anterior and posterior fat pad signs. And these are where you see a lucency anterior and posterior to the humerus, which indicate a bony injury. So if there's a bony injury, you'll get bleeding into that area of fat that resides in those fossae, and that will elevate up the soft tissues, giving the characteristic fat pad signs, which are present on this radiograph just here. And then the second line I look at is something called the anterior humeral line, which should intersect the middle third of the capitellum in children that are older than 5, and should at least touch the capitellum in children under the age of 5. And then lastly, I do always check the radiocapitellar line, where you draw a line down the axis of the radius, which on both the lateral and AP views should intersect with the middle of the capitellum. So to take an x-ray and go through those, on the lateral radiograph here we can see that there is an anterior and posterior fat pads. You can see that here. And if we draw an anterior humeral line, we can see that it intersects with the anterior third of the capitellum. And on the AP there is a dead giveaway that there is a fracture in the supracondylar region, which leads nicely on to understanding the classification for these, which in which is extremely useful for communicating with your colleagues. So to run through it, Gartland 1 is a minimally displaced fracture, typically described as displaced less than 2 millimeters. Gartland 2s describe a fracture where the posterior periosteum is intact. And a 3 is where that posterior periosteum is not intact, and so it's completely displaced. And then later additions to the Gartland classification include a 4, which describes both a extension and a flexion displacement of the fragment. And 2s have been split into 2 A's and B's, where B describes a posterior periosteum that's intact, but there's an element of rotational deformity. The significance of this classification and its management will become clear in a moment. And so going back to the clinical assessment then, once you've got your radiograph, you know there's a break. An absolutely fundamental part of managing these injuries is assessing and documenting the neurovascular status, which can be difficult in children, but it really is worthwhile taking the time to do this properly and, of course, documenting it properly. So I always check for sensation, and I typically do this on the uninjured limb first, so they get an idea of what you're doing and you build some rapport. So testing in the median, radial and ulnar nerve distributions as represented on that picture presented on the screen at the moment. And of course the motor components with children, I ask them to do various shapes with their hands. So I ask them to cross their finger, stick their thumb up in the air, make a gun and an OK sign to check the ulnar, median, radial and anterior interosseous nerves respectively. And then a really vital part of the assessment is the vascular assessment. And you can clearly feel the hand, check that it's warm, assess the capillary refill. But an extremely important part is to often you need to cut the cast back a little bit to be able to properly palpate for the radial artery and assess whether it's present, diminished or absent. Now, the management of the supracondylar fractures boils down to two things really, both a combination of the Gartland classification and the neurovascular assessment. So the Gartland classification lets you know whether this is something that needs conservative management or something that may need to go to theatre for closed reduction percutaneous pinning. So the Gartland ones can be managed either in a cast or potentially even just in a sling. 2As are a slight area of controversy where some surgeons choosing to manage these conservatively, some choosing percutaneous pinning. And then those that have a rotation element, so the 2Bs, or the ones that are grossly off-ended, like the 3 or 4s, clearly need percutaneous pinning. And then the second element of the decision was based on the neurovascular assessment. So for those that do need theatre, a decision needs to be made as to the urgency. And I break these down into 3 groups really. The first of which are those that are non-urgent. So those are patients that can wait overnight. And the patients that fall into that group are those that have closed injuries. They have no issues with the neurovascular status. On the other end of the spectrum, you have those that are clearly need to go to theatre emergently, so as an emergency. And those are children presenting with a pulseless, poorly perfused hand. And so you'd be wanting to book these patients into theatre day or night, giving a vascular surgeon or a plastic surgeon the heads up, as there could well be a brachial artery injury. And then the area that is slightly more controversial are those that fall into the urgent camp. And as per the BOAST, so the British Orthopaedic Association Standards of Trauma Guidelines on supracondylar fracture, these shouldn't wait overnight. And the ones that fall into this group are those that have sensory nerve deficits, where there's excessive swelling, or the brachialis sign, which is where the humeral spike has pierced through the brachialis muscle, causing significant bruising over the anterior elbow. And the group that causes a lot of difficulty is those with a pulseless, as in you're unable to palpate a radial pulse, but a well-perfused hand. Now, ideally, these go to theatre on the same day, but the controversy arrives when a patient's presenting late at night, so say midnight. Now, my take on this is that there's no right or wrong. You've got to make a decision based on the resources and the skills that you have in the setting that you work. And you can argue it either way at midnight. There are various papers demonstrating there's no difference between outcomes if you wait more than 8 hours or less than 8 hours in this group. But equally, there's papers such as White et al., who looked at, I think, over 330 patients with a pulseless well-perfused hand that went to theatre, and it demonstrated that I think it was at least half had remained pulseless after the closed reduction, and of those, 80% had significant brachial artery injuries. And a paper like that would strongly advocate not delaying taking these patients to theatre. And finally, I just want to touch on some of the surgical methods. There's two main ways of doing these percutaneous pins. One is the configuration of cross wires, demonstrated by the middle picture there, or lateral divergent K-wires on the picture on the far right. And again, different surgeons will have different preferences. My feeling is based on, and my preference is to lateral divergent K-wires, based on a meta-analysis performed by Decker, which showed that and discussed that whilst there are theoretical biomechanical advantages of cross wires, there was no difference in the loss reduction between the two configurations. However, a significantly higher rate of ulnar nerve injury, approaching 4% in those choosing to place a medial K-wire. So again, it's having an understanding of the risks of the surgery that you're planning to perform and ensuring you minimize this. So really, the pearls of wisdom for managing supracondylar fractures for me are always consult the BOAST guideline on this when you're starting out seeing these patients, as they give very clear guidance on how to manage them. And then I think my second pearl of wisdom is to have had a discussion with your various trauma consultants as to what their feeling is regarding managing warm but pulseless hands, and what the prevailing ethos is within the department that you're working, so that when you are presented with this, you have a rough idea what to do with it. Thank you.